Welcome to Lecture 4, Bias, Confounding, and Random Error. In previous lectures, we've looked at the PICO format, comparing outcomes between groups, and we've talked about the different types of study designs and conclusions that can and cannot be drawn from them in terms of causal assessment. Today, we will look at three major aspects of medical studies which are present and may lead us to false conclusions about the research if we don't control for them. In order to trust a study's results and apply them to practice, we must determine that bias, confounding, and random error do not interfere with our conclusions. By the end of this lecture, you should be able to determine the mechanisms by which false conclusions can be reached in scientific research, namely the three mechanisms in the title. You should be able to describe methods for controlling for bias, confounding, and random error, if they can be controlled for. And then 3, you should be able to detect bias and confounding in clinical studies. Let's start the lecture with a clinical conundrum. Let's say a patient comes into your pharmacy with an advertisement with Dr. Oz's face on it. The ad reads, in a recent comparative study, patients who took Oz Nuggets had a 40% lower risk of heart attack than patients who did not take Oz Nuggets. Dr. Oz has even included a 2x2 table in this advertisement because he knows how important they are to evidence-based pharmacists. So on the left-hand side, we have the exposure, the Oz Nuggets, and yes, no. On the top part of the chart, we have heart attacks, which is our outcome, yes, no. To get the relative risk, we would take the yeses, so heart attacks, new heart attacks that occurred, divided by the population at risk for the Oz Nuggets group, divided by the incidence of heart attacks in the placebo group, so yes divided by population at risk, 150 over 500 divided by 250 over 500 equals 0.6, and that's how Dr. Oz is saying that he has a 40% lower risk of heart attack. However, before you give your patients Oz Nuggets, is there any more information regarding the study that you'd need to make an informed decision? Think about this throughout the lecture. Let's start with bias, which tends to be the component of internal validity assessment that is the most misunderstood. We'll also look at a couple acronyms to help us remember biases in studies. The definition of bias we're going to use in this class is a systematic error in the design or conduct of a study that leads to an erroneous association between the exposure and the outcome. Bias is generally not the result of investigator prejudice, so it's not usually intentional or malicious. Rather, it's usually a foreseeable consequence of study design and conduct. Bias has magnitude and direction. So in terms of magnitude, it can make a relative risk of 2.4 appear as a relative risk of 2.1 or 2.7 or 5.1, so it can have different magnitudes, and it can have different directions, so it can make the association further from the null, which means that the association is stronger, or it can push the association toward the null, so we think that there is actually no association when there truly is one if there wasn't bias present. Unfortunately, little can be done to fix or mitigate bias once it is already in a study. So investigators must carefully design and conduct the study beforehand to avoid biases, but we need to know about them as readers so that we can consider them for internal validity and think about how they might affect the outcome of the study. There are many different types of biases which are described in the medical literature. We're going to put all of our biases under two basic umbrellas, selection bias and information bias. Selection bias in observational studies can be defined as errors due to systematic differences in characteristics between those who take part in a study and those who do not. In other words, the patients who we're assigning to our exposure or outcome groups don't truly reflect the overall population of that disease state or nation or whatever you're studying, so that when the study is done, the association that you find between the variables is not the true association you would find in the real world. Errors in selection bias in randomized control studies tend to be errors due to systematic differences in the characteristics between the comparison groups. In other words, patients with a particular type of baseline characteristic are more common in one group than another group. This is usually called a confounding variable or a potentially confounding variable, and it will be discussed in video 3. The other type of bias is called information bias, which is a flaw in measuring the exposure or outcome data that results in different quality or accuracy of information between the comparison groups. So as where selection bias is generally involved in the recruitment and assigning of patients into different groups, information bias is after a study is already kind of set up. It's when we're measuring and analyzing outcome data. Let's look at selection biases in the context of an observational study. So selection biases occur in observational studies when differences between the study groups due to the method of assignment or recruitment affect the outcome that is being measured. So this can either be on a control or on an exposure, but let's first look at controls. So control selection bias is common in case control studies. Let's say that you're involved in a study where you want to determine if pap smears aid in the prevention of cervical cancer. So you take 500 women with cervical cancer, those are your cases, and you ask about whether or not they've had a pap smear within the previous year, which is your exposure. You then identify controls by canvassing neighborhoods during weekday hours. And it turns out, on the left-hand side of your screen, these are your observed results, exactly 40% of your control patients and 40% of your cases have had pap smears in the last year. So when you go to conduct your odds ratio, you'll find that the odds ratio is 1.0. The exposure rates were exactly the same, and the outcome rates were exactly the same. So the odds ratio is 1.0, indicating no risk or no benefit of pap smears. However, there was bias in the way that you selected your controls. So it turns out that if you canvass neighborhoods during weekday hours, you will preferentially select patients who are unemployed, lack health insurance, and don't regularly seek medical care. So if we go over to the right-hand side of the screen, this is what you would actually see if your control group was selected in a less biased fashion. If you actually had a representative control group, you would see that many more of these patients get pap smears. And if you rerun the numbers, the actual odds ratio is 0.17, indicating that pap smears are preventative for cervical cancer. So we see in this case that bias has a magnitude. It changed the odds ratio of 0.17. It changed it to 1.0 through bias in the control selection and direction. So it pulled the odds ratio towards the null. In other words, it made it appear as there was actually no effect for pap smears when there truly was. Let's look at our other two selection biases. So just as we can have control selection bias, we can have exposure selection bias, which is a little bit more common in cohort studies. Let's say we're interested in knowing the impact of smoking cigarettes on heart attack incidence. So we take 10,000 cigarette smokers compared to 10,000 cigar smokers, and we say which type of smoking is essentially worse for you in terms of heart attacks. And heart attacks occur in 400 cigarette smokers and 700 cigar smokers over 10 years. So the relative risk is 0.4 over 0.7, or about 0.57. So it seems like cigarette smoking is safer. But cigar smokers are more likely to be middle-aged men, whereas more women smoke cigarettes. And men tend to have more heart attacks than women in this particular age group that we're looking at in the middle age. So if we look at just men in both groups, we would find that the heart attack incidence is actually the same. But since we selected our exposure the way that we selected it, had essentially a confounding variable, or it was associated, the exposure that we selected was associated with the outcome. This biased the results of our study. So we need to be careful in who we're selecting in our control and exposure groups. The last type of selection bias we'll talk about is attrition bias, sometimes called loss to follow-up. And it occurs when participants in one group leave the study to a greater extent than the other group for reasons that are related to the outcome. But attrition bias can also just confound the study results and make it very difficult to interpret in general. In one particular study, it was a condom distribution study that measured the impact of condom distribution on HIV incidence in Africa, found that the incidence of HIV dropped significantly in the condom group compared to the control group. However, 54% of all the participants in the study dropped out, which makes the results really difficult to interpret because we're not measuring outcomes from patients who drop out of the study. And the easiest way to control for this type of bias is simply to ensure that you follow up for outcomes with every single patient that you enroll. Let's turn now to information biases. Biases in information for measuring outcomes can come from three basic sources: the memory of study participants, which is usually recall bias or reporting bias, the use of data from previous records, so this can be misclassification bias or assessment bias, or in investigator measurements or investigator bias. Information biases can occur in both prospective and retrospective studies, and information biases tend to occur after the study begins. So we have our patients selected, but the information biases occur when we're analyzing outcome data. The first two types of information biases we'll look at comes from patient outcome data, when patients themselves tell us the outcomes. Recall bias implies deficits in memory, and they occur when one group is more likely to recall events than another group. So this is very common in case control studies. For example, if study investigators are trying to determine whether children with spina bifida had mothers who had sore throats during pregnancy, the study may show many more sore throats, 40% versus 5%, in mothers with children with spina bifida. This may lead you to believe that there's a high odds associated with a sore throat causing or leading to, at least being associated with, spina bifida. However, this is more likely due to the fact that mothers of children with spina bifida have had far more time to dwell on their past pregnancy and may remember things that mothers with healthy infants would not. So I've written a little bit more detail in the notes section of this PowerPoint, but essentially recall bias is more likely to occur when subsequent events are traumatic. So having a child with spina bifida may be traumatic, and therefore you may subjectively remember events that are more easily forgotten by people who have not had a traumatic event. Reporting bias is a little different, and it occurs when one group is more likely to report what they actually remember. It's not a deficit in memory. For example, if you have a study which examines how many sexual partners men diagnosed with gonorrhea have had in the past 2 months, men in the gonorrhea group may report more partners, say 3 versus 2, because they are required to call their partners and tell them to come in for treatment. But men who don't have gonorrhea don't need to call their partners and help them out, so they may downplay their actual number of partners for reasons of modesty. This would lead you to falsely believe that people with gonorrhea have more partners when they actually may not. It may just be the result of reporting bias. The next two types of information bias we'll look at are assessment bias and misclassification bias. Assessment bias can be considered an inaccurate measurement introduced by instruments that are used for outcome assessment. For example, if you wanted to study if NSAIDs cause gastritis or stomach inflammation, you might conclude that if you compared ibuprofen and naproxen, that both do not cause gastritis if you're using an abdominal x-ray to assess gastritis. But this is simply because abdominal x-rays cannot measure gastritis. So even if ibuprofen caused 10 times the incidence of gastritis than naproxen, you would never be able to know because you have an assessment bias because of the tool you're using. This causes your result to be biased towards the null in this case. Misclassification bias, also sometimes called measurement error, is introduced when one group is incorrectly classified as belonging to another study group. Say, for example, in a study of blood thinners used to prevent heart attacks versus placebo, some patients without heart attacks may be incorrectly classified as having had heart attacks. Thereby, you put patients who had one outcome into the other outcome group, which can skew your results. This can happen not just because of mistakes, but because you might have, say, a very broad outcome category. Say for heart attacks, you're looking at any person with chest pain or angina and counting them as having heart attacks, when really you should be using a much more narrow assessment and using much more objective criteria in order to categorize patients for your outcomes. And the last information bias we'll look at is investigator bias, which can be defined as systematic differences in soliciting, recording, or interpreting information based on knowledge of the study or study groups. Let's say, for example, you have a randomized control trial in which you're assessing a blood pressure medication against placebo. If you have a physician who knows the patient is on a blood pressure medication, they may be confused when a patient comes in and their blood pressure is high in clinic. That physician may ask the nurse to re-measure the patient's blood pressure, which may have a lower number on the second measurement, which fits with the physician's thoughts and personal perception of how the blood pressure should look. But a patient who came in on placebo likely won't get the same treatment. Rather, the investigator will probably keep the first high measurement. So investigator knowledge of the study led to differences in how the outcome was measured and recorded. The easiest way to control for this type of bias is blinding the investigators and the patients, which can lower the risk for this substantially. Let's recap what we've learned about biases thus far. So biases can lead to erroneous associations between the exposure and the outcome and generally cannot be removed from the study after it has occurred. Appropriate planning and conduct are required to reduce biases in studies. So it's investigator error in not planning and conducting the study appropriately. But as readers, we need to be sure that we look out for these types of biases so that we can make sure that when we do apply study results to practice, we're only applying results that are valid and bias-free. So the types of bias we've looked at are selection and attrition bias under the selection bias umbrella, and recall, reporting, assessment, investigator, and misclassification biases under the information bias umbrella. Selection biases tend to occur during recruitment, group selection, and follow-up, whereas information biases tend to occur following study enrollment. And the additional phases are left here as well. This could be a good slide, to study for your midterm and for your quiz before class. It can be difficult to remember where to look for biases. Luckily, the Rambo Man acronym can help us out a little bit. So places to remember to look for biases in studies include the recruitment phase, the allocation phase when we're assigning groups, the maintenance phase, so how many people are staying in the study, blinding of investigators and patients, objective measures, and analysis. So RAM usually involves selection biases, and Bowman typically involve information biases uh, due to outcome assessment. Here's a more detailed look at our Rambo-Man acronym. So R for recruitment, we need to ask, are recruited participants appropriate for the study's objectives? Do they match the overall population, and will they give us an appropriate assessment of an association between the groups? The possible bias involved here would be selection bias. Allocation, is group allocation appropriate and are groups well matched? This can also lead to selection bias either on the observational study or an RCT. Maintenance, are participants maintained in their groups? Did they remain compliant and did they remain in the study? So this would be what we would call attrition bias. Blinding, were patients or investigators blinded and were the statisticians blinded? This is information bias. Information bias can also occur if the measurements we're using are not objective or appropriate, and if the analysis that we're using is not objective or appropriate.